Well, friends, welcome to this edition of Understanding Corneal Topography and Pentacam. And my last presentation on this topic had generated a lot of viewership and interest. And I understand that there are a lot of tomographers and topographers in the market with a lot of data that we can generate and we get at our fingertips. And it is very important that we understand these tomographers and topographers in a systematic way, try to simplify it and understand what we need to do to improve the patient outcomes. Generation topographers would give you at least a few of these quantitative indices, and some of the things that are very important for us to understand is the simulated keratometry or the SIMK, to also understand the pupil coordinates, the pachymetry apex, and the thinnest location that is given by the Pentacam, the surface asymmetry index, which is given by most topographers. Of course, the very important are the angle kappa and the angle alpha, and the Q values of the eccentricity of the cornea or the surface factors. This Q value, eccentricity of the cornea, and the surface factors are all the same. Understanding one means that we suffice the others. Well, let us start with the simulated keratometry reading, and you will find it in all topographers. What the SIMK means is that if you have to compare your topography reading, the keratometry reading with the what you get from the manual keratometer or basically any other keratometers, then you have to compare with the same case that you get from the topographer with your manual keratometers or any other keratometer. The same K is basically the value that you get from the central 3 millimeters or the visual axis in the cornea. And basically, this is the value that you get from the anterior cornea. The sim K or the simulated K is not reading that takes into account the posterior corneal curvature also. It's only the anterior cornea. And why it is because if you have to compare it with the manual keratometer or the autokeratometers, they only give you the values of the anterior cornea and they do not take the values of the posterior cornea. Get from the anterior corneal curvature pictures can be of many shapes and many patterns, and the figure 6 actually shows a symmetric port tie, and here you can go in and implant a toric IOL in the patient, and for all others, probably you will give a second thought of whether to implant a toric IOL. Though figure 7, which is shows a skew shaped, and if that skew shaped is more than 22 degrees, you may not want to implant a toric IOL. However, if the skew shaped is less than 22 degrees, you may implant a toric IOL. And basically the next picture I will show you what I mean by a skew shift. As you can see over here, this picture, it shows a skew shift but less than 22 degrees, so you can implant a toric IOL. These are basically the shows the not regular astigmatism, and as you can see, it has a clap claw design, which shows basically that the patient might be having PMD or pellucid marginal degeneration. And the slit lamp image also shows that the corneal thinning in the periphery. About the Now let's talk about the Q factor, and we know the Q factor is basically describes the shape factor of the cornea, and this is related to the spherical aberration that the patient might have, the amount of spherical aberration that the patient might have. So normally the cornea can be is prolate shape. Where we mean by prolate is that it has a steep um, cornea in the middle, and in the mid periphery it is flatter. So that's basically prolate cornea. And a patient, the more it would be prolate cornea, the lesser the spherical aberration. On an average, the prolate cornea would be around minus 0.26, which would have a spherical aberration of around plus 0.275. is the slope of the cornea, and the corneal surface may take one of the four main shapes like the spheric, the aspheric, the oblate, or the aspheric prolate or aspheric hyperprolate. So if the Q value is positive, that is meaning that it is more than zero, then the cornea means it is oblate, and if the Q value is less than zero, what it means is that the cornea is prolate. However, the cornea can be hyperprolate if it is more than -1, and a Q value of zero is means that the cornea would be more of a spherical in shape. So the normal value is between 0 to -1. And in keratoconus patients, Q value is highly negative, and that is one thing that you should be watching for. And again, after a very high myopic photoablation, you can have a Q factor which is very hyperprolate. The Q value can be positive. Abnormal Q value causes, we know that is spherical aberration, so that is something that we need to watch out for spherical, for multifocal implantations or refractive procedures. So, where would you find the Q value in the Pentacam? As you can see over here, the Q value, you can get the Q value of both the front cornea as well as the back cornea, but a special watch out for the Q value in the front cornea, and that is very important. You should, if you are deciding on the multifocal implantation, you should watch out that the Q value is a negative and between 0 to -1. Here is of particular importance here is the pupil center, the pachymetry apex, and the thinnest location, and also to take care of the x and y coordinates, that is, which is highlighted over here. So very important is to look into the x coordinate of the pupil center because that signifies angle kappa. Unlike the op scan, which gives you a direct angle kappa, here you have to look into the x coordinate of the pupil center, which signifies angle kappa, and it should be less than the 200 microns or 0.2. And you need to also look into the pachymetry apex, and which should be not be less than at least 470 microns. And for the thinnest location also, you should look into the x and y coordinates, the y coordinate signifying horizontal displacement. So we know the x positive and the x negative, which signifies the horizontal offset of the pupil center or the thinnest locations also. And we also have to note the y positive and the y negatives, which actually signifies the decentration along the vertical axis of the thinnest location or the pupil center. And so that is important, and we will look into some of the examples to correlate. So let's take this example. If you see the pupil center x coordinate, we know that it signifies angle kappa, and this patient has around plus 0.15, which is less than 200 microns or 0.2, and that's fine with this patient. But if you look into the difference between the pachymetry apex and the thinnest location, this difference is under 10 microns, which is it needs to be under 10 microns. Always, again, I repeat this. The difference between the pachymetry apex in the pentacam and the thinnest location should be less than 10 microns. So this patient is doing good with that parameter. And the next thing that we need to look at is basically the thinnest locations x and y coordinates, which shows whether they are offset. And you can see in the x coordinate it is offset, and it is displaced horizontally by more than 500 microns, which is not acceptable. Anything more than 500 coordinates microns is not acceptable. It is 0.7 over here, meaning that it is 700 microns. Hence, it is against. We are not going to take this patient for the multifocal implantation. However, if you look into the y coordinate is quite natural that it would be inferior, so it is minus, and it is less than 500 microns or zero point 0.5, so the patient is good with that. However, the patient should be falling into the exclusion criteria because the thinnest location is well over 500 microns so far as the x coordinate is concerned. All right, let's take the next patient, and you can see in this patient has a Q value of minus 1.20, which means that this patient is hyperprolate, and the K values also relate to that of over more than 50 diopters. And if you see this picture, the corneal curvature is very asymmetric for this patient. Well, one other thing that we also need to look into for this patient is that you can see the red boxes that signifies that basically the superior and the inferior pachymetry differences is huge. It should not be, the difference should not be more than 30 microns, but here the patient has more than 30 microns of difference, which basically is not acceptable. Again, I repeat, the difference between the superior and the inferior, the pachymetry is more than 30 microns, which is actually not acceptable for the patient. Well, now in this example, you will see that the patient has the penis location x coordinate, which is at minus 1.06, which is more than zero point 0.5 or 500 microns, which shows that the penis location is horizontally displaced, and therefore this patient again is not a great candidate for the multifocal implantations. In this example, the patient has the thinnest location at the y coordinate, which is again inferior, but it is inferiorly displaced too much, minus 1.31, which is again more than 500 microns. And this patient again is a suspect and is not a very good candidate. So this is some of the considerations that we have to look into. So let's come back to the angle kappa that we had been discussing a few minutes back. And we said that the pupil center's x coordinate signifies the angle kappa in the pentagram. This is what we mean by the angle kappa, the difference between the visual axis and the pupillary axis, and that in terms of the obscandi, you get the direct angle kappa. It is actually 5 degrees would be acceptable. Anything beyond that is not acceptable. But probably a concept which has become more important now is the angle alpha, which is basically the difference between the limbus center, or where the IOL is going to center, the center in the bag, or which you can also say as the optical axis of the IOL, and the visual axis. So while angle kappa means the difference between the pupillary axis and the visual axis, the angle alpha, which is many surgeons regard this as very important, is the difference between the limbus center, or basically the optical axis of the IOL, and the visual axis. We say optical axis of the IOL because it is the limbus center is where basically the bag is going to ultimately center, and the IOL is in the back. So that's the optical axis of the IOL and the visual axis difference. The angle alpha actually we will be getting in the eye trace and some of those instruments, where you will be getting the angle alpha, which should not be more than zero point 0.5. So that's basically about the angle alpha and the angle kappa. Well, see you again, and thank you for your active listening. We will be talking more about corneal topography and corneal topography bringing in more new concepts. Till then, goodbye. Stay well.